Thank you, Dr. Kagan. Thank you, Dr. Kent. I'm sure we have questions, so I'll open it to the floor for questions for Dr. Kent and Dr. Kagan. There's a microphone here and one on the other side as well. And if you're online, you can submit your questions, and I think we have some coming in. But I actually want to, I have so many questions for both of you, but I'll just start with Dr. Kent. You know, the presentation you made about the glycemic, you included the control of drugs. But if we simply look at the patients who were either on any treatment for diabetes before they had their stroke versus those who are no treatment, and regardless of their blood sugar, did simply being on any treatment mitigate the effect of the stroke?
So it's a good question. There is some evidence that if you come in on anti-diabetic treatment, particularly metformin, that they did have a better outcome. So it does look like there's some benefit from that. There was a fair amount of data that actually now has led to a new drug, that if you're on a sulfonylurea drug, that you have a reduced chance of hemorrhagic transformation and edema. And that's actually led to an intravenous version of that drug for acute stroke in phase 3 trials. So yeah, I think it's good. You've been started on something.
Great, great. And we have some questions coming in. I'll rephrase one of these a little bit. So, Dr. Kagan, if we, you know, some of the patients will be on an ARB or an ACE. Is there any value to switching within the class? And do you find that there's variability among the agents, or are they all pretty similar?
There's definitely variability among the agents. So let's talk about ARBs. I think that's actually more commonly used now. You know, the ACEs, because they have a little bit more side effect profile, cough being a very common one of them, and the angioedema. So within the ARBs, if you look at things like losartan, that is the weakest of the drugs, right? And then you go up to olmesartan or Benicar, or they're the stronger of the drugs. So there's definitely variability, and you know, at times it's worth switching within the class. Issues with pharmaceutical industry production of meds actually have forced us to switch around a lot, because there were issues with valsartan and losartan. So we've had to do a lot of changes within the class of those medications, and the effects are definitely a little bit differently. So I think it's worth at least considering.
I just had a quick question for Dr. Kent. Can you hear me?
Yeah.
First of all, thank you for that really eye-opening presentation. The one question I wanted to ask you was, when we were talking about race and hyperglycemia, do you feel like the socioeconomic characters also change those results? Like knowing that certain race does not do well with TPA versus doing well with TPA, do you feel like the location where they're staying also makes a difference?
So that's a really good question. How do these results interact with the whole socioeconomic climate and setting in which the stroke has occurred? And I don't think there's any doubt that it's involved in that. That, you know, and it's not just the acute stroke; it's everything that led up to that stroke. And so, you know, we're heavily involved in the issues of disparities in outcome, and it becomes very complex. But fortunately, there's a lot of interest in that, particularly in those communities in which this is a significant problem. But yes, I think that the socioeconomic factors definitely contribute to outcome, and post-care as well. Access to rehab, access to secondary prevention, it's all part of this situation. But I do think there are some specific biochemical things about hyperglycemia, but it does interact with all these other factors.
And I think we have a question from Dr. Calapalo.
Okay, thank you so much first. So my question is, we see some patients who have like low blood pressure at baseline running in the 90s over 60s for years, and this is their baseline. And we know that their arteries have been adapting to this level of blood pressure. So what do we do when their blood pressure is 120 over 80? It's still within the normal for the population, but do you consider that normal for those patients, and what do you do usually for those patients?
That's a really great question. I don't think there's really a lot of data to drive that answer. In a clinical practice, when somebody changes their blood pressure, right? So they're always hypotensive and now they're normotensive. That's a relative hypertension for them. Or vice versa, if they're always really hypertensive and then becoming, low blood pressure. I think it's worth checking, making sure there's something that happened. So like in the case that you've described, somebody who's had historically very low blood pressure, all of a sudden their blood pressure spikes. I'd look, let's say, at their renal arteries just to make sure that there is not something that happened, right? Of course, medications would be another one. There might have been either taken a new medicine or a different medication that started. Chemotherapeutic agents are a really good example of that. All of a sudden, they'll have a spike in blood pressure. So I think figuring out clinically what has happened is important. Whether or not I would treat a blood pressure of 120 over 70 at that point, I'm not sure. I think it's a case-by-case situation.
And Dr. Kagan brought up the issue of sleep as it pertains to blood pressure. Any evidence that sleep, how it affects hyperglycemia or other outcomes was that something one could control for? It's harder to find, data for sleep apnea, I think, in some of these databases.
Oh yeah, that's it could be involved. There's all these things that contribute to insulin resistance. I think the more we pay attention to them, the more we aggressively treat them. If it's primary prevention or secondary prevention, I think ultimately focusing on all the causes of insulin resistance are going to benefit the patient, and definitely sleep apnea is one of those.
Well, we really appreciate it. Excellent way to start. I feel like we're going to hear all about stroke. In some ways, what we're going to hear for the rest of the day is a small percentage. And yet when you look at like hypertension and hyperglycemia, that's the large percentage of what really drives the eventual event and the stroke. So thank you so much for kicking it off. And we'll take just a very, very brief break for 1 minute to let our speakers switch off. And then we'll be back in just 1 minute to introduce our keynote address.